everyone. This is a new podcast slash video cast that your hosts here have started. It's called RetFix and Chill. We've realized that, we spend a lot of time talking about our interesting cases and we learn a lot from each other. So in the spirit of combining Retnaw's and Jay Sridhar's excellent Straight from the Cutter's Mouth podcast, we thought that this might be a helpful forum to share interesting cases and learn a little bit from each other. So just briefly, some introductions. I'm Sarwar Zahid. I'm a retina specialist here in New York City in private practice in Queens.
And I'm Nitish Mehta. I'm also a practicing retina specialist, and I'm at New York University.
And I'm Mike Andrioli. I'm also a retina surgeon at Northwestern Medicine.
So these are all people that I know for a long time. Mike was a senior fellow when I was at UIC for retina fellowship. Nitish was my co-resident. We were at NYU together. And so the topic today is actually something that we all tackle when we face tough diabetic detachments. And it's called crunch syndrome. And Nitish, why don't you tell us a little bit about a sort of a definition of what crunch syndrome is?
Right. So when we talk about crunch syndrome, we are talking about within the spectrum of proliferative diabetic retinopathy. So you have patients that have some form of preretinal neovascularization, and you're on the process of trying to dial that back. And that could either be with anti-VEGF injections or panretinal photocoagulations. You may or may not have some form of tractional detachment already at that time. But typically we'll treat and over time things should ideally calm down. But this is a paradoxical syndrome where you start a anti-VEGF treatment of some kind and you end up with a rapid worsening, usually about 1 to 6 weeks after your treatment, in which you've gone from, say, a small detachment to a large, really fibrotic response. Complete macular detachment, potentially with regmatogenous involvement as well. So you can go from a TRD to a TRRRD, or somebody would say flat PDR, and now they do have a TRD. So it's one of these feared, rare complications when you're starting off trying to do the right thing, and patients end up getting really, really worse, and so your hand is sort of forced. And this is a scary phenomenon because you might not be prepared for it, and the patient may up having worse complications down the line because they've moved 3 or 4 steps up in the severity.
Great, excellent definition. And I think we always face this. So I'm going to briefly show a case of mine from a couple of years ago where the patient presented with bilateral PDR and neovascular membranes, no frank TRD. And I'll be pausing the video here and there to just talk about what this patient has. This is, as you can see, it's the left eye. You can see there's a broad fibrovascular proliferation. And just to note, when I was doing the PRP, my decision was PRP both eyes, Avastin in the other eye. What I noticed during my PRP was that there was some lattice superiorly, and that'll be relevant later after we start the treatment. So this is an example of crunch syndrome. You can see here the severe neovascular membranes, PRP applied, and 2 weeks later, you can see in that little corner, a little finger will pop up there. I'll go back just a little bit here. You see right here at the tip of the distal superior arcade, a hole has popped, and that actually detached the entire macula. And the detachment actually extended all the way to the superior lattice lesion. And with a contact lens, you could actually see the strands of vitreous connecting the superior proliferative membrane to the superior lattice. So it's sort of a true crunch it's going out to the periphery.
What was there before you did the laser? Did you see anything there at all, or?
Nothing that was visible. I was able to PRP. Basically, during this PRP, I lasered also around the lattice. I treated it just prophylactically, because it's lattice. I'm lasering everything else. I mean, I thought about crunch, but it's not something that I it was so obvious, afterwards where you could see the vitreous contracting from the superior arcade all the way to the superior lattice. It was actually pretty fascinating. So this is, combined 25, 27 gauge vitrectomy. We'll talk about techniques we like to use. So I had done Avastin 2 days prior to this case. This is sped up like 4x. So you can see the entire macula is detached. And as always, we isolate the posterior cone of vitreous, as we all learned in fellowship. And once I've done that, even before going posteriorly, you can see that the superior lattice has actually torn 2 breaks. So I'm segmenting those areas and doing a 360 shave prior to tackling the posterior membranes. But this was something I haven't experienced, where there was basically, in addition to the macular detachment, also the peripheral detachment and actual horseshoe tears. I always like to stain with steroid. I switched to a 27 gauge cutter here, and it really lets you sneak in the bevel into the membranes. And once you elevate a plane, it really allows you to do it safely. Here, I'm being a little less gentle because I already know that there are several breaks and I need to get all this off. Using the cutter as a blunt tool as to delaminate is actually very helpful. One thing I've learned over the years, we've all learned, is that you don't need to take all these plaques off. You just need to relieve all the traction. And Maria Baracol often leaves large areas of plaques and has very good results. So that's one thing that I've sort of learned from watching her videos and hearing her talks. Yeah, some of these membranes were. This is before I decided that I wouldn't leave the plaques. This is a year after fellowship. I'm like, I gotta get all these plaques off. So I pulled out the scissors, and UIC style, and started to take these membranes off. I always like to restain, and you can see that break there. That's the break that was pulled during the after the PRP that we showed initially. I'm using it as a sort of drainage retinotomy and doing a little more peripheral shave as much as possible in this phakic patient. I don't have an assistant here, so I'm just doing, tilting the eye to maximize my peripheral shave. As always, doing a 360 scleral press exam, especially because now we have a peripheral rhegmatogenous component. And the rest of this is just PRP. And in this case, I did C3F8 gas. I could have probably gotten away with SF6, but sometimes you make these judgment calls during surgery, and you're like, all right, you know what? I'll feel better. I'll sleep better at night if I use C3F8. This patient actually did very well after the gas resolved and after they had cataract surgery. They ended up somehow 20/30. So this is a nice result. But as we all know, that some of these results, actually, no, sorry, I did not use gas here. I used oil. Okay, I remember this a little bit better now. I used oil in this eye because the other eye had gas, because the other eye had a TRD already. So I remember I did the other eye first, and now, I don't want to make this poor, like 45-year-old guy blind in both eyes. So I went with oil in this eye. But thankfully he did well in this eye. I'll stop sharing the screen now. So that's how I sort of managed that case. I learned a little bit, it was a pretty, big learning case for me, just to be careful, especially if there's peripheral lesions. So Mike, why don't you tell us a little bit about, your experience with this syndrome, what some pearls on some of the risk factors, and what points you towards worrying about Crunch syndrome?
Yeah, I think it's a little bit tricky. I think even the diagnosis is sometimes a little bit ambiguous, because I think there's kind of a wide spectrum of it, where this is more of a case where maybe it was converted earlier to a rhegmatogenous component, so it kind of changed how the tractional detachment behaved after the PRP. And then there's more situations kind of hinted at earlier where maybe you have membranes that are pretty flat in the macula, you inject anti-VEGF, and those membranes just pull anteriorly and cause a detachment. So it's kind of a two ends of the spectrum in my mind. I haven't seen great data in terms of the true incidence of it. I agree, like Nitish said, that I find it to be relatively rare, which is good for us. I think it's probably, in my mind, overstated when we're thinking about using anti-VEGF in these eyes. It can also happen with PRP. So in my experience, it tends to be eyes that tend to already have a bit more membranes. Maybe they aren't causing us as much traction initially, but they definitely can change the way that contraction of the membranes occur after we treat. My first case as an attending that I would call crunch was similar to yours. It was a very young patient. They're about 31. They didn't have a bad detachment initially. I actually did PRP, and it was a pretty thorough treatment. I usually am doing like 3,000 or 3,500 spots at least. And he developed a pretty nasty tractional rhegmatogenous detachment, went hand motion within a few weeks. I acted quickly like you did. He had a great outcome, but you aren't guaranteed those in those young bad detachments. So it's a bit hard in my mind to figure out which patients are going to go down this route. I tend not to have it high on my list of worries, admittedly. Usually, in my experience, the cases that go this route are, a bit more advanced. So I'm not going to hold off treatment for them necessarily just to worry about crunch. And I personally am not really a surgery until needed kind of guy. So I'm usually not jumping straight into a vitrectomy on a diabetic with a lot of membranes unless I feel that it's needed.
Got it. Thank you.
Here, I got a case. So,
Great.
are we thinking about crunch here? Are we worried about it?
Yes, I am.
I am, but I still, like I said, I probably wouldn't change my management for fear of it, but it's definitely a case where I can imagine that superior arcade having trouble.
I'd probably start with
So
PRP here.
for your first approach, macula's on. There is detachment along the arcades. Does it change if you're going to start with anti-VEGF or PRP? The order, does it matter?
For me here, I would start with PRP. There's, like, people say, PRP, the effect is a bit more gradual rather than the big bolus of anti-VEGF. We haven't really shown that to be consistently the case. I mean, I think it's a patient by patient basis, but in this case, I would sort of blast the periphery with PRP and do it in several sessions, and add in the anti-VEGF if there's any vitreous hemorrhage or worsening macular edema.
Yeah, I think that's very fair. I admittedly am more of a laser kind of guy than an avastin kind of guy for membranes. Um, in this situation, it doesn't look quite as fresh. It's not quite as perfused from what I can see in the photo. I'm sure in a fluorescein it would show it's a bit more active. I don't think PRP is unreasonable here, especially if you're thinking you're going to go down the surgery route. There's actually some older data showing benefits to having more preoperative PRP when you're going in for a vitrectomy in these eyes.
So single session or multiple session, does it change the outcomes?
I don't personally have any data I've seen to show it. I am a get as much PRP in one session as I can kind of person. If they can't due to discomfort, I'll stop it. But I feel like with a Pascal, I can count on one hand the number of times I've stopped a PRP session and without getting full treatment, unless there was blockage from vit heme in my career.
Mm-hmm. Yeah, I think I agree. I mean, I try to tend to go kind of as much as the patient can handle. Oftentimes it's pretty specific. I think there's been one case in my experience where I did a full PRP and the patient came back with exudative choroidals and had some significant cell. So, I don't think there's any data to guide this, but, a patient that I'm kind of a little heavier handed on, I might send them home with a week of Pret Forte, might just be treating myself, but
Sure.
sometimes I'll do that. I definitely try to put down laser first, but the trick is I feel that sometimes if you say you have someone with a macular detachment and your first step is you're putting down laser, you start doing the case, and then say for example in Sarwar's case, now you have a break, and now you have hyaloid down throughout the posterior pole, and now you're starting to having to lift up because by our tenets of surgery, if you have any rhegmatogenous component, all hyaloid must come off, right? and now you're trying to lift over thin lasered retina. Have you ever encountered problems with that? Sometimes I get a little, if I know they're macular detachment, I know I'm taking the surgery, maybe I'll just do Avastin a couple of times and maybe just some gentle PRP in the periphery, but not totally laser that eye down, knowing I might have to pull the hyaloid totally off. Do you guys follow?
Yeah.
Yep, I think that's reasonable. In those situations where the hyaloid's super sticky and you're causing more trouble than benefit you're gaining, I won't necessarily lift it all the way to the periphery, but like you said, you need it at least to the near mid periphery in those cases when you have a break.
It's actually really interesting that I've experienced that. If I mean, a lot of times I try to get in some laser because, a lot of our attendings said like, get as much laser as you can. You're helping yourself. You're getting some treatment in. But actually, like in those areas, I've seen pop holes, no matter even if you propagate the PVD very gently. So I think, how heavy your laser is makes a difference. I mean, if it's heavier laser, you're more likely to encounter that. Like over time, I've actually tried to, I don't have a Pascal. I use an Iridex pattern laser. I've actually, for two reasons, I've actually gone up on the size. I mean, instead of doing 200, I mean, I think back in the day they used to do like 500 or 1,000, but I think, we've overall, 200 is like what I learned in residency and I use most often. But increasing the spot size and, concomitantly increasing the power has given me, slightly better sort of control of that. But as we all know, it's always dependent on the patient.
Yeah, so this is that same case, a couple rounds of PRP after and actually one injection later. And you can see the detachment does encroach more posteriorly. Some other new lesions on the edge. There's a little bit of loss to follow-up here. You can see it's starting to get a little chronic. There's some subretinal bands superior nasally. And so is this crunch? I'm not really sure. This is natural history of this disease process. I always tell, the way I like to describe to patients is, you're on a bullet train and we're pulling the emergency brake. That train's gonna go another half a mile before it stops. So we're putting out a 5 alarm fire a bucket at a time. The house is still gonna burn a little bit before we can actually put it out. And I think that's a helpful way to describe to patients because the worst thing that happens in these cases is, paradoxical worsening in our hands at the time of treatment in, a poorly understood disease process, at least most times from the patient perspective. So, we should be aware that these cases do potentially worsen before they get better.
Yeah, I think that's a fantastic point that's missed, especially by people earlier in their career and training, that not every detachment that progresses or not every bad PDR with some membranes that turns into a detachment is crunch. I mean, the process will continue, like you said. I feel like a lot of the times people are like, oh, I injected Avastin, and 3 months later they detached. It's like, what a bad outcome, bad case of crunch. I don't think those are crunch. I think that's just bad disease. Those are very perfused, mature vessels sometimes. Anti-VEGF is awesome, but it's not perfect. And even if it shuts down those vessels, it doesn't remove the contractile tissue with it. So I totally agree that we probably overused the term, and I think that's probably why people are a little bit more afraid of it also.
Hmm. Hmm.
Yeah, for sure. Those are all great cases, Nitish. I'll share a couple of additional cases and then we'll
I wanted to ask you one question about your surgery.
go ahead.
You had a patient with a very posterior hole, and you peeled hyaloid off of the macula. Do you ever find value in other adjunct dyes, like putting in tissue blue or ICG to really confirm that your macula is free of tractional membranes? Is any good experience with that? Has that proved valuable?
That's a great point. I mean, over time. So this was early on as an attending. So my cases were a little bit longer. So I did not use dyes at this time for diabetic detachments. I restained with steroid and I found that to be pretty helpful. But as I've gotten more efficient with surgery, worrying less about losing my view, which is, something, it's like the bane of our existence. I'm always complaining to people. It's like, yeah, how's your OR day? Yeah, the view was crappy. Like you just deal with it. because it's interesting how we all just deal with that. But over time, I have, especially on the OCT, if I see a little bit of an epiretinal membrane, it's harder to get all of it just with that initial sweep with the cutter and peeling those membranes off. So I've started to use more brilliant blue, and that's been helpful more recently. In this case, I think part of the reason I got lucky is just because there weren't too many epiretinal membranes. Like epiretinal membranes, as in like traditional epiretinal membranes, aside from the proliferative vascular membranes.
Yeah, there's not a whole ton of data in the TRD realm, but there was a paper in 2022 in Retina that looked at ILM peeling, and it didn't seem to affect the outcomes in terms of Preop rate, but it did seem to improve anatomical outcomes and visual outcomes when there was ILM peeling. So I think it's a reasonable thing to do. But generally, when I'm dealing with a bad TRD, that's not my highest priority, to be honest. I just want that retina reattached. If you have a great view and things are not bleeding, things like that, I think it's reasonable to go the extra mile to get the ILM off. But it's definitely not my main goal when I'm doing a posterior TRD.
Yeah, I think I've definitely leaned on it if it's somebody's, re-op, rather than primary case, then I'll definitely try to stain. Um, and then, we talked a little bit about just laser combination. Um, I do find that I recently did a TRD without Avastin on board, kind of just for this process, just like possible for a little bit of laser. And that oozing is real. I hadn't seen it in a long time, and I've never had to use the diathermy so much. And so I find that it definitely makes a difference. The Avastin makes a difference in terms of our ease of surgery.
Yeah, pre-op, 100% agree. The only time, like you said, I had one that just logistically, the patient was coming from far away. I was trying to spare them the injection, and same thing. I immediately regret this decision. I wish I had injected him. So there's pretty decent data on that now. Pre-op Avastin definitely decreases bleeding. We've all seen it. That's a definite for me when I'm about to operate, for sure.
That's great. Yeah, same here. I always use pre-op Avastin. I'm going to share a couple of quick cases, and then we'll summarize with sort of pearls that we all use when doing these cases. So I'm going to share a couple of cases here. Can you see this image here?
Yeah.
This is a 28-year-old diabetic, came in with bilateral sort of, bad PDR with a little bit of edema. All I did was PRP here. They were lost to follow for 3 months, and then they came back with a worsening detachment in this eye. Ultimately, they ended up under oil. This is what they looked like a week after. It was a really tough case. There was a lot of bleeding, and this is under oil. And as you know, I'm sure we've all experienced, if there's blood in that interface between the oil and the retina, that takes forever. It really doesn't go away well. It actually forms a fibrous plaque, and when you go back in later, oftentimes you have to actually peel it off, and it's stuck to the retina. The
Yeah,
question
so
is,
I'm taking someone back next week because they have blood under oil.
yeah, it sucks. So you just have to be really patient, and sometimes staying under the fluid phase can really help to sort of mobilize the membranes, and also sometimes you'll notice that they come off in chunks. It looks like bits and pieces of cake. So I like to switch to reflux and just like blow onto the membranes, and you can see it sort of breaking off. And sometimes that's a bit less traumatic than actually grabbing with the cutter or forceps, because you don't know where the adhesions are underneath. As you guys talked about, so eloquently earlier, the question is, in this case, is it because of the PRP that I did, or is this just natural history? And this is an ongoing poor glycemic control with an A1C of 12 to 13. This poor type 1 diabetic, which is it's a tough situation, tough social situation. It's a tough disease. This may have happened even in the absence of treatment. Shifting gears just a little bit, people talk about crunch in other conditions. This is a case of a patient with proliferative sickle retinopathy with PSR who presented with a left eye subhyaloid hemorrhage. And you can see here the peripheral membranes. In this case, there really wasn't any obvious TRD, but you always worry in this case in the young patient. I've seen uh, sickle cell detachments; those are not fun to do. In this case, I got a little bit lucky. I just did Avastin, the heme cleared, and did the usual sector PRP. So in this case, I got a little bit lucky. Interestingly, I have some cases coming up. So this is a case I have coming up soon that already has some detachment. Actually, no, I did this case already and actually ended up doing okay. So there is a big macular traction that in the inferior arcade is extending into the fovea. So there's a big VMT there. So
What I was talking about earlier, where you've got a very, very aggressively lasered atrophic membranes, thin retina, you do a break in this eye, it's very hard to get out of this situation.
yeah. So in this case,
So
actually,
wonder,
I
I
didn't do
mean,
that.
is the fovea really detached? Like, is this actually a patient that needs to go to surgery?
So I waited like 6 months, and the fovea was detached. It was a big. I'm sorry, I don't have the OCT, but it was tented up from this inferior membrane. And in this case, to your point, I did not say. I mean, there was not a PVD present, and I treated this as a true TRD. All I did was relieve the traction, remove the membranes inferiorly, and there was. You see that nasal RD there. All I did was segment over that area. And this is a pseudophakic patient, so I could do a pretty decent shave. I did not try to peel the hyaloid beyond the macula.
Just a little snip, 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 leave it.
That's it.
It's a great example, yeah.
Yeah. And so I'll share one more case here. So you can see here, this is another type 2 diabetic, actually. I don't know how well you can see it you see it here, but this is very there are a ton of neovascular membranes in the periphery. The peripheral retina is super ischemic. You could actually see it without a fluorescein. So this is one of those cases where like, all right, I don't need a fluorescein. The text asked me, do you want a fluorescein? I'm like, nah, we're good here. So in this case, as you mentioned, flat neovascularization. This was super flat. There was no RD. I was not worried at all about it. There was a little bit of edema, but I just basically blasted the peripheral PRP with a 300 spot size, 4x4 grid, brought them back over multiple sessions, and they were mad at me because they developed vitreous hemorrhage after the PRP. But thankfully they've done okay. So any thoughts on this case?
This is a slow and steady wins the race, in my opinion.
Yes, I agree. I'll stop the sharing now. So we'll do a quick summary. We'll start with, why don't we start with Nitish? Say you suspect crunch, really bad diabetic detachment. What are your pearls in trying to, we talked a little bit about Avastin, talk a little bit more about that, like timing and things like that. How do you prepare before the surgery, during the surgery, and things you do to reduce the risk of rebleed after the surgery? And
yeah, so I think we've discussed a lot of these points already, but the primary one is just be prepared, right? And what does that mean exactly? So if the patient has a bad cataract, get them in with the cataract surgeon, establish that relationship, and at least make sure that they're ready to get on the board to remove the PSC. Because if you've got a detachment that's going to take 2 hours, you don't want to be doing a combo case because your hand is forced by changes. Secondly, that will probably start their medical clearance process. A lot of these patients have out of control sugars, possibly cardiac risk factors. You might need to do your surgery at the main hospital. So you don't want to end up in a situation where you've given a patient a treatment such as Avastin or a PRP or whatnot, and you don't have a game plan for what's going to go next. Say they progress, and then say that they're not a medically viable candidate patient for surgery, you can end up in a pretty tough situation. So I definitely think that making sure you're looking at the patient as a whole globally and coming up with a game plan. Sometimes I'll actually just put in the booking orders and start the process for booking maybe about a month out, knowing that I'm going to do a couple rounds of PRP in between it, and I can bring it up faster if anything comes back. And I think as we've discussed here, there's no real right or wrong answer. There's no real right or wrong choice on sort of treatments, but gentle. If your patient potentially looks more ischemic, maybe just go a little bit slower and be a little gentle and just keep them close, watch them close.
Great, great pointers. Any thoughts on how soon before the surgery you do Avastin, Mike?
Yeah, I generally try to do that 4 to 7 days before surgery if it's feasible. I'll be a little bit flexible on either end, logistically if needed. That seems to be a sweet spot in my experience. He already went over a lot of the great points for it, just things I'll throw out there in terms of pearls. If you're going in for a tractional attachment, pre-op Avastin. I don't necessarily do every Vietnam diabetic that way. If it doesn't make sense, if it's easy enough logistically, I'll do it. If not, I don't stress about it as much as the TRD. If I'm going in knowing it's a relatively straightforward TRD, I'm mostly a vitrector kind of guy. I usually start like the peel over the nerve with forceps, and then I'll often switch to a combination of forceps and vitrector. If it's a total disaster that I know I'm getting into, I'll put in a fourth port with a chandelier, and I'll do a true bimanual with forceps and vitrector most of the time. We already mentioned perils of oil. I try to avoid oil and bad diabetic detachments if I can avoid it. Sometimes you have to. I would honestly prefer to put gas in and let it fail than put oil in a lot of time though. So unless I feel like I really need it, I'll try still gas. I find that if you've cleared the membrane sufficiently and you have a reattachment because a break wasn't fully lasered well enough, those are pretty straightforward cases. The ones when you're not getting all the membranes off and they're reattached are a disaster. So I try to avoid those. I tend to, like you said, UIC style, try to just clear out all the membranes in the first surgery, and then it makes your life usually much better down the line.
Great pointers. I also like to do Avastin pre-op. I actually try to do it as well for the heme cases, just in case there's a little bit of oozing. I try to do it 2 to 3 days if possible, especially if I'm concerned about severe contraction or if there's already been some contraction. But I agree. I think, we overstate our fear of this. I've seen people not do Avastin in a timely manner and have detachments progress because of the natural course of disease, and I think it could have helped. I think all the surgical pros discussed, I think are great and things that I use all the time. I actually haven't had to do a lot of bimanual lately. I've just been doing a lot of 27 gauge cutter and using the flex loop. I do a lot of these cases at the hospital, so thankfully, I'm able to use some additional tools. I think oil is, not ideal because they're gonna bleed, and it, I try to do Avastin at the end of the case as well. That can help, but I mean, if a patient is poorly controlled, oftentimes, it's not in your hands.
Yeah,
Okay,
sure.
guys, great points, everyone. Thank you for all your insights, and that's been our first episode of RetFix and Chill. We'll be coming at you with some more surgical cases on a monthly basis, and if anybody wants to participate, just reach out to me, Nitish, or Mike on the several forums that we all participate in or in person, and we'll be happy to have you come and participate. Thank you so much. See you, everyone.
Thank
Thanks,
you.
everybody.